our 108th episode of Happy Learning Masterclass web series. So I welcome Dr. Mrutyunjay Bellard sir, who has kindly consented to be chief guest to bless the webinar. Of course, Dr. Bellard is good old friends and he is always with me in any of my academic activity. So welcome Dr. Bellard. I also welcome two guest of honor, Dr. Vidya Dubey, President Kasoga, and Dr. Asalata Mallapur Madam, past President of Bagalkot Society. And both have kindly consented to be guest of honor to bless the webinar. Of course, both are with me in any of my academic activity since long. So welcome. I also welcome learned speaker for today's very interesting talk on medical management of fibroid, Dr. Rasi Paladi from Gulbarga and Secretary of Kasoga. I also welcome three learned chairpersons who are going to chair that very important session. Dr. Durgadas Asrana from Tumkur, Dr. Suguna Madam from Bijapur, Dr. Usha Dudamani Madam from Gulbarga. And I invite all and welcome all panelists who are going to bombard question in this panel, because this time it is reverse panel. Panelists will be asking a question and being a moderator, I will be answering. So I invite all those panelists and welcome all those panelists. Dr. Ratna Kuntoji Madam from Bagalkot, Dr. Shobha Shavi from Bagalkot, Dr. Sweta Patil Madam from Belgaum, Dr. Vasant Lakshmi Madam from Mandya, Dr. Sila Muddur Madam from Mandya, Dr. Sailja Madam from Tumkur, Dr. Rachna Madam from Tumkur,
Thank you,
Dr.
sir.
Sangamesh from Bijapur, Dr. Santa Durgi Madam from Basav Kalyan, Dr. Nita Arwal Madam from Gulbarga, Dr. Manpreet Kaur Madam from Bijapur, Dr. Subhas Mudnur sir from Bijapur, and Dr. Soumya Patil Madam from Gulbarga. I also welcome Dr. Asha Jain, convener, not for this webinar only, but she as a convener in this series since long. So welcome Dr. Asha Jain. I also welcome two coordinator, Dr. Bharti Rajsekhar and Dr. Rekha Rajendra Kumar. They both are convener for today's webinar, as well as in so many episodes. Bharti Madam had been coordinator and Rekha Madam is also coordinator in this series since long. And see the commitment on part of Dr. Bharti Rajsekhar, just mentioned by Dr. Asha Jain. She has traveled a lot abroad and then she has come today only and she has joined this webinar. So thank you, Dr. Bharti Madam, for the same.
Thank you very much, sir.
Yes, yes. So as mentioned by Asha Jain Madam, she is going for committee chair, perinatology committee. So all the best, Madam, for this for your
Thank you, sir.
future
Thank
endeavor.
you, sir. Your blessings are very important.
Yes, yes. And I welcome all the president and secretary of respective society who have joined this webinar. Bagalkot, Belgaum, Bijapur, Gulbarga, Mandya, and Tumkur, and all the delegates who have joined this webinar. So in era of COVID-19, where physical meetings were not possible, I started this series with three other friends, and now it has become a very vast family of 7,000 plus member as far as Happy Learning Masterclass web series is concerned. So I am happy to announce that also. And every time we go with focus topic, today we are going to discuss medical management of fibroid and reverse panel as far as medical legal issues in our day-to-day OBGYN practice is concerned. So with small remark, without wasting much of your time, welcoming you all again. Thank you very much.
Dr. Manpreet may not join for the faculty. She is in emergency case. That's what she's told. If she finishes, she'll join it since. So.
Okay.
Yeah.
Request Dr. Bharti to please introduce Dr. Bellard. You are muted, Dr.
Namaste. Yes, namaste. Thank you, Dr. Asha. My greetings to Dr. MC Patel and all the esteemed faculty from Karnataka and from outside the state. It is indeed a privilege for me to introduce Dr. Mrityunjay B. Bellad, the teacher of teachers, a great academician who is known all over the world for his intense interest in women's health. Sir is a professor at the Department of OBGYN at the Kahir's JN Medical College and a senior consultant at the PK Hospital, Belagavi. And he's been the president Kasoga from 2018 to 19 and as well as the secretary in 12 to 13. He has a fellowship in perinatology from the University of Illinois, Chicago. He is the Global Network Scholar 2004 to 7. He's a principal investigator for international trials such as the labor trial, the CLIP, the preterm, the cradle trial, and the rapid iron trial, which is going on. And this has been kindling an utmost interest in all our Kasogians as well as the Foxians. He's a fellow of the FIC, as a fellowship from the ICOG, numerous publications in high impact factor journals, written 2 books at 14 chapters. He has more than 1,000 guest lectures at regional and international academic events. Google H index, he has about 20. That is the amount he has searched for. That's a high index search for Dr. M.B. Bellad's study reports, I guess. And he's an expert review member of the ICMR for Center of Excellence on Preeclampsia. He's received the Teacher of Teachers Award 2022, Best Scientist Award 2013 to 14, and Best Teacher Award 2010-11 from the deemed to be university. He has the MS Signature International Award for Phenomenal Leadership and Excellent Academician 2020, the Newton Baba Award from MRC London and DBI India for the Cradle Trial. And I guess he has many more, which he has not mentioned here. Over to you, Dr. M.B. Bellad, sir.
A very good evening to all my colleagues, and special thanks to Dr. M.C. Patel for making me the chief guest for today's webinar. I have to invite first that my daughter's wedding is scheduled on 18th of this month, reception on Sunday. So I welcome everyone. So I requested him, but at least to be a chief guest. Sir, you are a great person, great academician. I once again thank you for your encouragement and the firm thirst and endorsed on me. And special thanks to Dr. Bharti, who introduced so much elaboration. I think we should reduce all that because our slide will depict everything, but more concentration on the academics. But thank you, Bharti, for that elaborate introduction. The global woman, I can say, who traveled not only 6 continents where I have visited, but she has gone to 7th continent, that is Antarctica. I don't know, one more is left, Arctic.
They have discovered an 8th continent, it seems so. Let's wait and watch.
No, that is the 8th one is Arctic, the northern one. This is Antarctica is the southern one, and the northern one also, which
Sir, one more Australia has discovered under the sea.
Maybe I don't know.
It's still being under research.
See, this is an explorer, which is an evident now. Say that eighth, it will be 9th continent. So thank you for that, and respected co-chairs, Dr. Vidya Tobi and the Rajeshri Palladi and Rekha Rajendra Kumar and all the esteemed faculty members, panel members, and both from within Karnataka and outside Karnataka, and our OBGYN colleagues. It's indeed a proud privilege to be the chief guest today, and at a session which is, the topic is of really important, because every one of us, embark on moment fibroids are diagnosed. So we go for the surgery, but there is a scope for medical management, especially it will be of help. At least it may be temporary, but definitely it has some role to play. And that is what is going to be highlighted today. And, fibroids, I always teach in my classes, today's word, woman is marrying late for her career orientedness. She is becoming pregnant very late. And after the pregnancy period also, till the menopause is a longer period. So in the Jeffcott, it is said that uterus that is deprived of fetuses consoles itself with fibroids. And this is aptly true, because that environment leads to occurrence of all these problems. And fibroid, you can name, which can mimic like a most benign without any symptoms to most dangerous condition. I had in my career 2 sarcomas, which were actually even the frozen was missed in them. Both cases, we had to refer for higher treatment to the Tata Hospital, Mumbai. So but now it is very clearly evident that sarcoma is a de novo compared to what was said that fibroids also undergo the sarcomatous change. So, and also it is very clear that now fibroids, whether they origin from the myometrium or the vascular and the tunica media fiber, and it is Rekha, I think you agree with me that it is the vessel artery tunica media of the myometrium from which the fibroids origin. But however, there are still questions on that. But now the current teaching is that fibroids arise from this media of the vessel. So I hope that those components are going to be covered in the discussion, and the most importantly, the medical legal aspects. Whether am I seeing the fibroid there, I have opened for diagnostic scopy, or I have doing something else. Can I proceed with the myomectomy? Or if I have done cesarean, there are weak fibroids, whether I can go ahead with that. So these, of course, there are clear guidelines, but however, Dr. M.C. Patel and his team will be covering on these aspects as well. So thank you very much for providing me this opportunity. I wish the the program, all the best. And Dr. MC, I have one more commitment that we have a labor study which we have completed. We are
Yes.
having a steering committee meeting, and there shortly, because we had the meeting in Paris about the final conclusion meeting of this labor study, we are going to have series of publications on this. Today, I am very happy to share with you all that is the new standardization of treatment of anemia. My article, where I am the first author in the biomedicines, it is published. The new standardization of treatment of anemia, how exactly we should plan and what should be giving in iron deficiency anemia is published. I can put that article sometime once it comes, the online published. Today it is been accepted, and I am happy to share, but I will be very happy to share that. So thank you once again, and wish you all the best.
Thank you, Dr. Bilal. First of all, I would like to congratulate you for this academic achievement. Of course, you are known for that. Whatever research project is there, or any pioneering work in any area as far as female health is concerned, you are always there, and you have done the justice to the job allotted. So congratulations for the same again, and thank you for sparing time to bless us for this webinar. And we are always blessed. We are always happy to invite you and to have you here in this our Happy Learning platform. So thank you very much.
Thank you, sir. Taking the program ahead, now we have our guest of honor, and I request Dr. Rekha to please introduce Dr. Asha Lata.
Yeah, thank you, Dr. Asha Jain. It's my privilege again and pleasure to invite one of my close friends as well as guide, Dr. Ashlata Malapur. Madam was traveling all the while, and again, as MC Patel sir said, it shows her commitment that she has come on time to join the webinar, and we are so happy for that. Madam has a very decorated, very rich CV, but her simplicity is to give us only few lines. As Bellad sir said, so we have to talk about the CV in short, and Madam has done so. Madam is, other than the CV, what she has mentioned, she is also the state level faculty for the PCPNDT inspection. Madam has done her post-graduation and diploma of obstetrics gynecology from MR Medical College, Gulbarga, professor and head of the department of S. Nijalingappa Medical College, 30 years of experience in teaching, academics, and lot of publications. Thanks for honoring us, madam, with your presence here, and we would like to hear your esteemed words. Over to Ashalata, madam.
Thank you, madam.
Madam, please show your
Thank
face.
you.
Yeah.
Thank you so much.
Welcome, madam.
So, respected sir, Bella sir, Asha madam, Rekha madam, everybody. And Vidya also, who is my close friend, Bella sir, and Dr. M.C. Patel has given me opportunity to be here today. And as you all know, webinars have become an essential platform for learning and knowledge sharing in today's digital era. These online seminars allow experts to connect with the global audience, sharing valuable information and insights. So MC Patel's webinar, this Happy Learning webinar is so famous. Every week we usually don't miss and we attend. And Dr. Rekha Rajendra is also very hardworking, and every time she calls without fail that today there is a webinar, madam, please attend. So thank you, Rekha. Even Asha Jain, madam, also had called us to attend the webinar, and it is going to help everybody. So thank you so much, sir. I wish the program all the success.
Thank you, madam. Thanks for being the guest of honor.
So thank you, madam, for sparing time. You are, of course, with me in any of my academic activity. And just mentioned by Dr. Rekha, it is your commitment that just you had been traveling and you have joined this webinar to bless the webinar. Thank you, madam.
Thank you, sir. Thank you.
Yes, welcome.
Dr. Asha, you have muted yourself. Dr. Asha?
Yes, yes. Madam.
No, Asha
Thank
Ji.
you. Thank
Sorry.
you, Asha ma'am.
Sorry.
Thank you, Dr. Rekha.
Yeah.
And now I would like to introduce my dear friend and senior, Dr. Vidya Thobi ma'am, who's the president of Kasoga presently. And Dr. Vidya, we don't have your CV. Wait.
Yes,
I
I
will-
think I have sent to sir, but anyway, President Kasoga is enough for me.
So ma'am is going for Vice President Foxy South Zone this year. And I request everyone to please support her. She is very senior, very deserving, and I don't have any more words to say. She's just so much of a dear friend. So over to you, Dr. Vidya.
Yes. Thank you, Dr. Asha, for those kind words. And I must say that what I should say about Dr. M.C. Patel, sir. I started my footsteps in Foxy because of Dr. M.C. Patel. He was my vice president when I joined as a Food, Drugs and Medical Surgical Equipment Committee, for which now Dr. Asha Jain is contesting, so support her as well. And Dr. M.C. Patel, at every step of mine in Foxy, he has guided me how to contact and collaborate with each one. So I owe a lot to Dr. M.C. Patel. He is also contesting for the presidential position, and I appeal to everyone for voting for him. That is first part. Second, I must talk about my own Kasoga. We had a wonderful, wonderful conference. I must say my secretary is there, Dr. Rajashri Balladi. Our president-elect is there, Bharti Rajshekhar, who had joined. Then Dr. Subhash Murnur is there, our Bijapur OBGYN president. And all my colleagues in Bijapur, we made it very successful. Dr. M.C. Patel, there also he conducted one reverse panel.
Yes.
And it was so successful. That was, I think he conducts many reverse panels like this. So, and every time a new questions arise and medical legal never ends. So every part of our practice, we are always facing medical legal problems. Dr. Rekha Rajendra Kumar is another gem of our Kasoga family. She's an infertility person, but she took this medical legal committee as a challenge, and she has done so wonderful programs. Actually, we gave her in the Kasoga conference mood court. What I'm going to, who is Dr. Vasanta? Please make it. No, please. Vasanta, that person I don't know. Make him mute. Yes. So she did it so well, and she is doing wonderful programs. And this is 178th program of Dr. MC Patel. So we should congratulate him for his perseverance and connecting each and every person in whole India. Wherever I go, Dr. MC Patel is very much there. And I also need his support as a vice president. I'm contesting this year. So I need everybody's support as well as especially Gujarat support is
Yes.
I seek from him. So thank you very much for inviting me as a guest of honor here. I am very sure that Dr. Rajashri Palladi, who is a truly academician, she's into research now. She's now research dean in her college. I saw once I attended her KBN University felicitation recently, and she speaks wonderful. So she is going to talk on medical management of fibroids, and I'm not going to dip in that subject because we are going to listen to her now. So I wish this program a very best, and I wish Dr. Asha Jain, and I must tell about Dr. Bharti again. Bharti is also contesting for our perinatology committee, and I must say that Karnataka should not fall back. So every committee chair from Karnataka should, and this one, everybody, president, secretary should vote for her, send nomination for Bharti Rajshekhar, and we see that our Karnataka people come up in Foxy as well. Thank you very much.
I'm not Karnataka, Dr. Vidya. Thank you, but please.
She is from Karnataka. I told about you also because my committee you are leading, no? Food and Drug Committee. So I have told you
yes,
about
yes.
you also. And maybe Shanta Durge will also come up in future. We both are state level advisory committee of PCP NDT here in Karnataka, sir. This is for MC Patel, sir, because we also interact about the medical legal problems. So
Yes.
thank you very much for calling
Thank you.
here.
Thank-
And I wish everybody all the best. Thank you.
Thank you, Vidya, for sparing time and kind words. Just to mention, when I was vice president, Dr. Vidya was heading committee, food, drugs, and medical surgical equipment committee, and I have seen her working since then. She is very hard-working person, and as far as her candidature for vice president South Zone Foxy is concerned, she is most deserving candidate, and I would appeal rather to all the delegates who have joined this webinar to vote for her. And as far as president and secretary of respective societies are concerned, in month of May, you will have to send nomination for her candidature as a vice president South Zone, and in month of August, you will have to vote. And same way, as mentioned by so many, I am also going to contest for post of president Foxy this year. And it's same way, in month of May, you will have to nominate, and in month of August, 1st to 10, you have to vote. So with this, thank you, Vidya, and all the best for your this Foxy endeavor.
Sir, MC Patel, sir,
Yes.
like your like your presidents, Dr. Vidya Tobi being a chairperson after you, now if you become president, we wish that you become president and Vidya madam as a vice president in your tenure.
Yes, exactly.
Let the same
exactly.
precedents continue.
Yes, exactly.
Yes, yes.
But if that is up to you all voters
Yes, yes, very
to
sure.
make it possible.
Yes, yes, we have been and we will continue to.
Yes, yes. Thank you. Thank you.
Yeah.
Dr. Rekha, would you introduce Dr. Asrana?
Yeah.
We don't have much of a CV, so if you know something, you would.
Yeah, yeah. I know I don't have the CV right in front of me, but I can introduce Dr. Asrana sir. He's our senior. He's a senior gynecologist obstetrician from Tumkur. He's from my same town, so he's like my big brother. And he's a very good person as such. Was the treasurer of Kasoga in 2020 to 22, avid academician. He also was the president of Tumkur Society, Obstetric Gynecology Society. Thank you, Dr. Durga Das. We would like to hear from you. We are so happy to have you here, actually.
Dr. Bharti, we are into the academic session. Sir is the chairperson.
ಇದು ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿದ್ರೆ ಏನಾಗುತ್ತೆ
Dr. Bharati,
Yes, yes, Dr. Asha.
please
ಮಾಡಿದ್ರೆ?
introduce Dr. Saguna.
Thank you, Dr. Asha. I request Vasanta.
Here, please mute Dr. Vasanta. Vasanta, madam. Yeah, muted.
Yes, thank you. Well, we have Dr. Suguna, who is a consultant from Suguna Maternity Hospital from Vijaypura. She's been the ex-professor of Alameen Medical College and a senior consultant at the District Hospital Vijaypur. She's the president of Bijapur OBGYN Society from 2017 to 19, and she's been the scientific chairperson of the State Conference of Bijapur and the EC member of the Kasoga in 2018 to 20. She's been the chairperson of the Emergency Obstetrics and Critical Care under the Kasoga at the present moment in 2023. She has participated in state and national academic programs as faculty, and her fields of interest are high-risk pregnancy and antenatal US ultrasound. I request Dr. Suguna to be the chairperson of this very interesting session.
Thank you, madam. Thank you, Bharti, madam. And all the best also.
Yes, thank
Now
you,
I
Suguna.
would like to introduce Dr. Usha Dodamani, who's the professor and HOD Department of Obstetrics and Gynae, Gulbarga Institute of Medical Sciences, Kalaburgi. She's the vice president of Kalaburgi Obstetric and Gynec Society in 2021. She's published papers in national and international journals. She was the South Zone Yuva Foxy awardee for paper presentation, master trainer in comprehensive abortion care and BMOC. She's a member of Maternal Death Review Committee Kalaburgi, and her areas of interest are urogyne and high-risk pregnancy.
Thank you, ma'am. Thank you, Asha.
Over to you, respected chairpersons, to now introduce our speaker and the topic.
And Mr. Tirth, please allow Dr. Rajeshri Palladi to share her screen also.
She can do it. It's already been done, Dr. Rekha. Now I request chairpersons to introduce Dr. Rajeshri.
No, when he is sharing, she can't. No, now he is allowed.
I am sharing.
Okay.
Shall I introduce?
Yes,
Shall I
ma'am.
introduce? Dr. Rajeshri Palladi, madam, is the Honorary Secretary of Kasoga, and she's the Dean of Research of KBN University. She's a member of IQAC, member of Academic Council KBN University. She's Professor, Department of OBG, KBN Kalburgi, and she's postgraduate and undergraduate examiner at various universities. She has presented papers and has presented guest lectures at various forums. She is the director and consultant in OBG Aditya Multi-Speciality Hospital Kalburgi. She's OBG and PhD team member, represented Rotary International from India and Australia Rotary member. And she's the organizing secretary of 25th Kasoga State Conference, Gulbarga. She's a past president, Gulbarga OBG Society. Welcome, Rajeshri madam, and she's a very active member. She's always present in all the webinars and always giving her feedback. Welcome, madam. Over to you.
Thank you, madam. Pranamam, respected MC Patel sir. Thanks for having me on board for this wonderful session of learning. And my respect to my president of Kasoga, Dr. Vidya Subbi ma'am, because of whom I have been representing Kasoga, and Dr. Bharti Rashekar ma'am for asking me to give this talk. And my due respects to all the seniors in Kasoga, the past president, Dr. Bellad, whom we heard give a wonderful briefing about how the significance of fibroid has emerged in the past and in the current year. And my respect to Dr. Asha Jain ma'am, who has been so simple that she has been always connecting and communicating with me and kept me updated about this webinar. My respect to my colleagues in Kasoga, the wonderful people because of whom we have been able to achieve and attain greater heights of representation in the nationwide, and we hope to see most of our seniors reach greater heights. We hope Dr. Vidya Kobi ma'am is there for us to represent at the FOXI national level, and Dr. Bharti Rajshekar ma'am at the committee level, and all the very best to all the respected participants and the contestants, including Dr. Asha Jain ma'am, to make the best representation and bring up the high levels of our academics and management of patient care for the nation. Thank you all for having me here on board. I also express my respect to my colleagues from all the societies of Bagalkot, Belgaum, Bijapur, Gulbarga, Mandya, and Tumkur, and the chairpersons for giving me such a wonderful introduction, Dr. Sibuna and Dr. Durgadas and my friend Dr. Usha. Can I share the screen, please?
Yes, ma'am, you can do it.
It is showing as disabled, ma'am. The host has disabled participant screen sharing.
That is what I told Tirth.
Yes, ma'am, I am making him host.
Yeah.
Rajeshri, all the best.
Thank you so much, ma'am. And before we
Ma'am, you
start,
can share it now.
Yes. Thank you. As aptly mentioned by Dr. Bellat, sir, this is becoming a scenario wherein the fibroids are an increasing number and posing a challenge for management in our practice, mainly so because of the changing lifestyle and the choices that we have made over the period of time. We know that the leiomyomas are benign monoclonal pelvic tumors, and fibroids now are affecting about 35 to 75% of the females in the reproductive age, more so in the 4th and 5th decade, wherein the incidence could be as high as 57.3%. And it so happens that routinely, when we do our ultrasound performed for other reasons, apart from the presentation of the fibroid, we invariably come across fibroids. And now we also see that the young women conceiving late in their life also have a number of fibroids which have been accidentally discovered during the ultrasound examination for the antenatal care. At present, 5 to 10% of the infertile patients have a fibroid, and fibroid itself per se can attribute to about 2% of the cause of infertility. So these are benign tumors of the uterine smooth muscle cells and also arising from the uterine vasculature, as aptly mentioned by Dr. Bellat, sir. And we find that when we do a hysterectomy, 30% of the causes for hysterectomy are directly related to the fibroids. In India, we have a huge mammoth population of 15 to 20 million who suffer from fibroids. So it is the initiation of the tumorigenesis, and this is now explained by the mutation which takes place in the cell. The further growth is dependent upon the sex steroids. So with the basic underlying factor being there, and under the influence of the sex steroids is what happens in the enhancement and the representation of the fibroid. But the role of progesterone now is established as the leading factor for growing or increasing the size of the fibroid. Previously, it was thought that both estrogen and progesterone, but now it is established beyond doubt that the progesterone increases the cell proliferation, it increases the extracellular matrix, it decreases the apoptosis, and estradiol, it merely induces the production of the progesterone receptors by means of the endometrium receptivity. And local aromatase activity is increased in the fibroid tissue. Some genetic factors are attributed, and we find that this is more prevalent in especially the large and huge fibroids, wherein translocations of chromosome 2 and 14 chromosomes have been depicted in some women, deletion of short arm of 7 chromosomes, trisomy of 12 chromosomes are found to be associated with fibroids. Leiomyosarcoma, although have a different origin. Now, the FICO has established a classification for understanding the site, the location, and to a certain extent, it helps in the management of the fibroid, for which I would not be going into the details. We know that they are normally named from 0 to 8, and giving a nomenclature or giving the number helps us to identify where the fibroid is located. We have what is known as the hybrid leiomyoma, wherein both the endometrium and the serosa could be involved, and these are the ones which pose a challenge for the treating physician as to understand what should be the modality of the treatment, whether it should be the medical or the surgical management, and therefore help us to establish the line of management. The classification of submucous fibroids is again into various types from 0 to 5. wherein the extent and the involvement of the myometrium is described. Type 0 is a pedunculated intracavity myeloma. Type 1, wherein less than 50% is intramural. Type 2, when more than 50% is intramural. Type 3, when there is a contact with the endometrium. Type 4, when it is totally intramural. And type 5, subserosal, and maybe up to 50% is in the intramural. Type 7 is subserosal pedunculated, and type 8 is others like cervical or parasitic. Now, initiate the promoters of the fibroids. We have the genetic and the epigenetic factors, and these act directly on the myometrium and thereby help in the leiomyoma growth. Now, these genetic and epigenetic factors, the epigenetic factors, namely the estrogen, the progesterone, the growth factors, the cytokines, the chemokines, and extracellular matrix components, initiate and augment the growth of the leiomyoma. The molecular genetics of progesterone is the ovarian progesterones act via the progesterone receptor to regulate the transcription of the key genes for apoptosis, proliferation, and ECM formation. The progesterone has dual roles. It stimulates the growth by upregulating the epidermal growth factors, and BCLA2 inhibits the growth by downregulating insulin-like growth factors expression. So what happens when there is a fibroid? The fibroid may have various symptoms, and up to 50% of the time there may be no symptoms at all. Like it could be a chance discovery when the patient comes for examination or any other presentation like pain in the lower abdomen or pressure symptoms. But in about 50% of the patients, it may present as dysmenorrhea, menorrhagia, metrorrhagia, and infertility, especially in the women who are trying to conceive. Due to pressure, there could be increased urine frequency, constipation, bloating or fullness in the belly, pain in the pelvis, pain in the back and legs, dyspareunia, or an abnormally large or enlarged abdomen, to the tune that after 20-22 weeks of pregnancy, as fibroid, there could be no complications or presentations or complaints that the patient may have. She just presents only with the bloating of the lower abdomen. So the menorrhagia, the dysmenorrhea, metrorrhagia definitely have a significant association, and these in turn can lead to iron deficiency anemia. So the first time the patient may present with iron deficiency anemia. So heavy menstrual bleeding is often the most important and common finding whenever the patient is symptomatic, and this may be associated with dysmenorrhea, that is a spasmodic type of dysmenorrhea. There could be heavy or prolonged menstruation, and this is generally the typical pattern of bleeding with the fibroids. And if there is an intermenstrual or postmenopausal bleeding, one needs to exclude the endometrial pathology. So whenever there is a bulk or the size of the fibroid, it may cause related symptoms in the pelvis like pain and pressure. And when there is an anterior wall, it can cause increased frequency of micturition, and the posterior wall of fibroid may be even difficulty in passing the motion. Large fibroids, larger than 6 centimeters or more, or equal or about 18 weeks in size, may cause hydronephrosis, and we have also seen venous compression occurring in large size fibroids. The reproductive complications could be infertility, recurrent pregnancy loss, and other complications of pregnancy like preterm, PRM, etc., which I am not going into detail. And she may present for the first time as an emergency whenever there is a fibroid degeneration when associated with severe pain and torsion or prolapse of the fibroid. So what do we have now in the current scenario, and when is it that we should start or initiate the treatment for the fibroids? Broadly, it can be classified as expectant management, medical management, and surgical management. In the medical management, we have a symptomatic non-hormonal treatment or therapy like the NSAIDs and the antifibrinolytics. The medical management, which could be as a just prolonging the surgical management or empirical treatment, or to reduce or buy time, could be the oral contraceptive pills, the progesterone releasing intrauterine system, danazol, GnRH analog, and now what is in rise is the SPRM derivatives and ulipristal. Surgical management, of course, we have myomectomy, hysterectomy, or uterine embolization. So what are the management options in medical? NSAIDs, antifibrinolytics. Traditionally, OTC is being used and also progestins is being used. Now we have the newer drugs. and other drugs like aromatase inhibitors, danazol, and cestrinol. I would like to mention here the non-surgical treatment other than the medical management could be uterine artery embolization, the magnetic resonance directed ultrasound, the endometrial ablation, and myolysis. Now, MRFUS is a rising trend in some of the advanced nations wherein they are using extensively for disintegration of the fibroid without resorting to either the medical or the surgical management. Now, we have the minimal invasive surgery like laparoscopic hysterectomy, robotic myomectomy, robotic hysterectomy, etc. When do we opt for a medical management? Is to decrease the size of the myoma and also to reduce the symptoms. It could be either in a perimenopausal woman or an adolescent girl and unmarried patients who want to defer the surgery. It could be a preoperative adjunct wherein there is a severe anemia or a large fibroid, or when there is an unresectable myoma. Limit that there could be a resurgence of the fibroid after stopping the treatment, and there are some advantages of the medical line of modality. So, non-hormonal treatment in women trying for conception mainly, that is the NSAIDs and the antifibrinolytics. These are not effective for fibroids associated with heavy menstrual bleeding, and the NSAIDs may decrease the fibroid related dysmenorrhea. That is, the dysmenorrhea associated with fibroids may be reduced, but it is not very effective in reducing the amount of blood loss, wherein we have to resort to antifibrinolytic agents like tranexamic acid given as 500 to 1 gram twice daily as a first line of medical management to control the heavy menstrual bleeding. Now, hormonal treatment like OC pills were effective in reducing the menstrual bleeding, but it is in the short term. There is no evidence that low-dose OC pills cause benign fibroid to grow. It could be used for treatment of mild symptoms, especially for women needing contraception. The second choice, the progestin, it causes endometrial atrophy and thereby releases the heavy menstrual bleeding, and both of these could be used, that is the OC pills or the progesterone, as a treatment for mild symptoms. Now, when we are looking at reducing the volume and symptoms, then what is choice? The choice would be the GnRH analog and the specific progesterone receptor modulator like mifepristone and levetiracetam acetate and aromatase inhibitors. When we are looking to elevate the symptoms, then non-hormonal treatment like tranexamic acid or NSAID, OC pills, progestin, and levonorgestrel containing intrauterine devices can be used. Drugs like GnRH agonists, SERM, raloxifene, ormeloxifene, danazol, gestinon, etc. are also quite useful in reducing the volume and symptoms of the fibroid. What are the limitations of the currently used pharmacological treatment, and why is it that there is a resurgence of newer drugs now? The oral contraceptive may increase sometimes the size of the myoma, although low dose are known or proven to show that it may not definitely increase the size of the fibromyoma. But we have to keep in mind that when we use over a prolonged period of time, there is a chance that the head will increase in size of the myoma. Also, it could be associated with breakthrough bleeding, and this is a very important definitive risk factor with OC pills, that is the risk of thromboembolism. Progesterone, they lead to inconsistent bleeding patterns, and it could have hypoestrogenic side effects, and it may lead to the formation of ovarian polyposis. And the levonorgestrel releasing IUD, it affects the size of the uterine myoma, but it is still a debated choice whenever the size of the uterus is huge or about 12-week size, and there is a chance of expulsion rate. So the approach like GnRH agonist can cause hot flushes, and it may affect the bone density when used for a prolonged period of time for about 6 months of time, and it requires to be administered by injection. And danazol have been almost given up because they have lots of side effects like hirsutism, weight gain, irritability, musculoskeletal pain, hot flushes, and breast atrophy. The symptomatic treatment, antifibrinolytic and tranexamic, have their own limitations because they do not reduce the size of the fibroid, and only the bleeding can be controlled. So what happened is that we are looking for newer options which are available, that is the selective progesterone receptor modulators. And these receptors, we know that the progesterone and the progesterone receptors enhance the growth of fibroids. So by default, it was evaluated that if we have a molecule which will act as an antiprogesterone, it will reduce the size of the fibroid. So these are a new class of PR ligands, that is the progesterone receptor ligand. displacing tissue-selective agonist or antagonist or mixed activity on the tissue with target cells, and they have anti-proliferative, anti-fibrotic, and pro-apoptic effects, and these put together will try to reduce the size of the fibroid. The first one which was evaluated was mifepristone, which emerged as a pioneer member in this class, was discovered way back in 1980. It was an antagonist approved for pregnancy termination now very well, and other drugs like asoprisnol, tenopristol acetate, onopristol, donepistol, vilapristin have been evaluated. Ulipristal acetate is another important specific progesterone receptor modulator. It is an antagonist with little agonistic effect. It has affinity to progesterone receptor and varying degrees of antagonist activity. Today, we know that mifepristone and ulipristal acetate are licensed for clinical use outside the clinical trials. How do they act is that they have a direct effect and they cause down regulation of the angiogenic growth factor, increase in the vascularization and leiomyoma cell proliferation. They cause apoptosis, they alter the progesterone receptor expression, they have anti-proliferative action, and ulipristal acetate was approved in 2014 for uterine leiomyoma in Europe and Canada. Long-term treatment of uterine fibroids with ulipristal acetate was recommended in the Journal of Fertility and Sterility published in 2014 June. But we see that eventually it had some drawbacks and there were some problems associated with ulipristal use. So these SPRNs act on the hypothalamus, pituitary, endometrial and uterine tissue. They inhibit the ovulation. It induces amenorrhea. It blocks
Rajshri ma'am, would you please put off your videos, because I don't know, some bandwidth is there, we can't hear you. So you were frozen, so put off your video and then maybe we'll be able to hear you better.
The thing is unstable, internet is unstable. Okay, is it better now? Ma'am, can you hear me now?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. We can hear, ma'am.
Okay. Okay. So mifepristone, asoprisnol, tenopristone, ulipristal acetate, vilapristin, etc. were the various drugs which have evolved, but only two important medications have stayed back. That is the mifepristone and ulipristal, because the other medications had some of the side effects and they still are in the trial phase. So as we see that the progesterone receptor antagonist effect increases with the pyramid that is seen, and somewhere in the middle is ulipristal acetate and low down is mifepristone, which emerges out as a better PR antagonist effect. So the spectrum of transition of progestational agonist to antagonist activity of the SPRM, and progesterone is a pure PR agonist, whereas mifepristone is often classified incorrectly as a pure PR antagonist. So this Cochrane data, which evaluated the efficacy of the various drugs like mifepristone, ulipristal, asoprisnol, etc., because it had a comparative analysis of 3 important medications, and these are very effective studies, 5 studies in mifepristone, 4 studies in ulipristal and asoprisnol, etc. So what was found was that there was an effect on the fibroid-related symptoms like AUP, pelvic pain, and the symptom severity decreased and the quality of life improved with usage of these medications. There was one significant side effect associated, that is the endometrial changes, the progesterone-associated endometrial changes. So what we found is that there was the SPRM for uterine fibroids improved the fibroid symptom severity in 20%, quality of life related issues improved in 22%, menstrual blood loss decreased by 60 to 80%, amenorrhea was brought in about 23 to 96%, and no conclusions regarding pelvic pain. SPRM associated endometrial changes were found in few cases. There is a discrepancy between the differential change in uterine fibroid volume, but universal improvements in bleeding symptoms were found. So SPRM mechanism underpinning the control of bleeding may be independent of the fibroid shrinkage, and this interaction is poorly understood. The medicine ulipristal acetate has been advocated 5 milligrams. It is an orally active synthetic drug approved by the European Union for pre-treatment, pre-operative treatment of uterine fibroids. And today, ulipristal is the most effective medication for conservative treatment of uterine fibroids. There were various trials conducted, the Pearl trial especially, Pearl trial 1 to 4 in the European centers in the Caucasian women, and there was a strict criteria of BMI cutoff. The other study was the Venus study 1 and 2, conducted in the United States in the African American women. Herein, no BMI cutoff was taken, and Premia was the real world data, and Premia has given a lot of information in the studies of ulipristal. All trials have demonstrated positive impact on the reduction of fibroid-related symptoms and the size of the fibroids. Pharmacokinetics and dosage of ulipristal. 1 tablet 5 milligrams is taken orally once daily for treatment for 3 months, followed by a gap of 2 menstrual cycles is what is advocated. And this comprises 1 treatment course. So when we say that there's a 1 treatment course of ulipristal acetate, she has taken uninterruptedly 3 months of 5 milligrams of ulipristal. The treatment should be initiated when menstruation has occurred. The first treatment should be started during the first week of the menstruation, and retreatment, that is after a gap of 2 months, should be started earlier during the first week of the second menstruation following the previous treatment course completion. Repeated intermittent treatment has been studied up to 4 intermittent courses of cycles of ulipristal, and if a patient misses a dose, she should take the tablet as soon as possible. And if this is missed by more than 12 hours, she should not take the missed dose and simply resume the usual dosing schedule. So what are the indications of UPA in fibroids? Woman less than 40 years of age presenting with symptomatic myoma informing the uterine cavity and thereby having infertility. In women more than 40 years of age presenting with symptomatic myoma, premenopausal women presenting with symptomatic myoma but who are not desirous for pregnancy and who wish to preserve the uterus and do not want hysterectomy. Contraindications, severe liver disease. This emerged as a very important component in considering ulipristal because it causes a lot of liver damage. Definitely shouldn't be used in pregnancy or when there is a genital bleeding of unknown etiology. Do not use in conditions of uterine, cervical, ovarian or breast cancer. Postmenopausal women are a no-no. Severe asthma insufficiently controlled by oral glucocorticoids, coagulation disorders and endometrial hyperplasia. Now, for some time, this was in fact withdrawn from the market and stringent rules were laid for the usage of ulipristal because 8 cases of severe liver injury were identified and 4 required liver transplant. So drug was banned for overall further safety review. The pharmacovigilance now announced that the status of ulipristal as a medication responsible for drug-induced liver injury is not still fully confirmed and has made some regulations for further usage of ulipristal. So liver function tests have to be performed before starting each treatment course and fortnightly thereafter during the drug treatment. It should never be given if the ALT or AST levels are 2 times the upper limit of normal, and it should be stopped in patients wherein the ALT or AST levels are 3 times in the upper limit of normal. Safety and efficacy of 2 repeated cycles of ulipristal in the management of symptomatic uterine fibroid in the Indian woman was conducted extensively in the All India Institute of Medical Sciences in Patna, and they have also come out with very good reports. Although there may be some side effects like headache, nausea, fatigue, dizziness, menstrual cycle length may increase, severe kidney and liver disorders, relative contraindications like asthma, etc. were published. But serious side effects remain liver injury. And this was especially in the ESMA study, wherein the all data across the all sex was conducted, and the European Medicines Agency issued an advisory in February 2018. So before initiation, we have to make sure that the AST and the ALT levels are normal, and it has to be definitely stopped and referred to a specialist hepatology whenever there are complications associated with the use of ulipristal. So it is now indicated for intermittent treatment of moderate to severe symptoms of uterine fibroids in women of reproductive age who are not eligible for surgery. So there are categorization of indications for uroplastol. One course of preoperative treatment of moderate to severe symptoms of fibroids in adult women of reproductive age, and it is contraindicated in women with liver disorders. So what is this progesterone receptor modulator associated endometrial change that we come across whenever we use this medication? That there is a unique pattern of endometrial change observed following the treatment, and this is termed as progesterone associated endometrial changes, and this is most commonly seen as cystic glandular dilatation with both estrogen and progesterone epithelial effect. Cystically dilated glands lined by flattened epithelium without the needed pseudostratification, and true endometrial hyperplasia and atypical hyperplasia has been observed following the therapy with the receptor modulator. And it is very important for the pathologist to differentiate from true hyperplasia. So there is a mixed component. It is a non-synchronous endometrium. There could be pseudostratification, there could be pseudodecidual stroma, and sometimes we have seen the report that there could be an evidence of pregnancy is what is reported as when we send the endometrial sample after doing the DNC in suspension. Abnormally dilated thin vessels with no evidence of atypical hyperplasia C, and despite the paucity of mitosis, this may be mistaken for endometrial hyperplasia. So similar incidents can occur even after one course or one cycle of treatment, and also 4 cycles of treatment, which is evident in about 25% of the patients who go through this therapy. And the total duration of the cumulative dose is not directly related to the occurrence of PSA, as has been evidence that even one course or one cycle of uloprostol can cause such kind of cystic glandular hyperplasia. But the good news is that it is rapidly reversible, and even after 4 or 3 cycles of the treatment schedule, within 3 months it comes back to normal. And repeated course of uloprostol did not increase the frequency, and after the 4th treatment cycle with 5 to 10%, also it could be an incidence of 15 to 10% of abnormal endometrial findings. So the next drug, which was extensively described as newer modality, is mifepristone, which was reported by Murphy in 1993. Dose as low as 5 to 60 milligrams are effective in ameliorating the symptoms, reducing the size or volume to the tune of 50%, and inducing amenorrhea in sometimes 100% of the women who are put on mifepristone. Ultra low dose is also found to be effective. It has resulted in appreciable symptomatic relief with a 11% reduction in uterine volume, suggesting that a possible dose effect with improvement in quality of life with as low as 2.5 milligrams. Longer duration of treatment, 6-month study with 2.5 milligrams, there was no further reduction in the uterine volumes after 3 months of usage, meaning to say that it doesn't give a validated explanation to use beyond 3 months, and 3 months is just enough, because even you give a prolonged duration, it will not have any added on benefit in reducing the volume or the symptoms. Even amenorrhea rates have reduced from 65% at 3 months to only 32% at 6 months, and no further volume reduction was seen after 6 months, and rather increased rate of breakthrough bleeding or spotting was reported. Intermittent therapy or administration suggested for long-term mifepristone use with treatment duration of 3 to 4 months, followed by an off-drug interval till menstruation has occurred, has been published in the Contraception Journal. It is now known that endometrial thickening with more than 3 months treatment is due to the cystic dilatation and not due to hyperplasia, and still intermittent therapy would be more reassuring for the clinician. The Cochrane meta-analysis shows that moderately it is effective in bleeding and improving the fibroid-related quality of life, and no effect on fibroid volume, that is only the bleeding and the quality of life improves. In another meta-analysis which was published, it shows that when given for 3 to 6 months, there is a significant reduction in the uterine and leiomyoma volume. There is alleviation of the symptom and no atypical endometrial hyperplasia. And this was 11th RCT, the random control study. In our own AIM study, low-dose mifepristone in medical management of uterine leiomyoma, an experience from the Tertiary Care Hospital in North India, which was published by Vidushi Kurukshetra, Anka Kriplani et al. RCT is to compare 2 doses, that is 10 versus 25 milligrams was given for 3 months, and mifepristone in the dosage given for 10 to 25 milligrams gave a symptomatic relief with more than 90% reduction of the mean blood loss. So it was found that amenorrhea develops in about 90 to 95% of the patients. It is reversible. Greater reduction in the size of the myoma. Endometrial changes specific to the receptor mode occur. Some side effects like leg cramps and hot flushes and repeat endometrial histopathology did not reveal any complex hyperplasia or atypia, and myoma does not regrow immediately after stopping the treatment, but symptoms do recur immediately after stopping the treatment. Another prospective study, interventional study, was conducted to evaluate the effects of medical therapy on the management of uterine fibroid by Nita Gupta in the Department of OBG in Jammu. So they also had a similar kind of result, and they concluded that resulted in a reduction of the uterine fibroid size and increase of the hemoglobin at the end of 1 year. Various other studies have also been shown, and especially the one published in the Journal of China says that the pre-treatment with mifepristone before laparoscopic myomectomy could gain ideal therapeutic efficacy and reduce the intraoperative blood loss and blood transfusion rate. So this was the beneficial effect that we had of mifepristone. Coming to other actions or other medications available now, the GnRH agonist, it acts on the anterior pituitary, it acts directly on the receptors and fibroid, reducing the proliferation of the myoma tissue. It has direct action on the pituitary, reducing the regulation and desensitizing the GnRH receptor, producing a hypogonadotrophic state and consequent reduction of the estrogen and progesterone level. The current recommended dose is only to the duration of 3 to 6 months, and especially so only in the preoperative period, but not as a definitive management. The drugs advised are leuprolide 3.75 milligrams and goserelin 3.6 milligrams. Side effects, as we all know, the initial flare symptoms, plasmodium symptoms, decrease in bone mineral density, recurrence to the previous size within several months after stopping the treatment, and difficulty in shelling out the pre-treated myomas. Either it could be because of degeneration or obliteration of the pseudocapsule. FDA has approved the use of leuprolide and iron preoperatively in women with leiomyoma, but not as a direct medical management of these tumors. The other drug available, that is the GnRH antagonist, it competes with the endogenous GnRH for pituitary binding sites. It has a rapid onset of clinical effect without the initial setup as seen with agonist, but the long-acting preparations are not available and they require daily injections to treat the leiomyoma. Oral GnRH antagonist elagolix has been recently approved by FDA for treatment of endometriosis, but this is not still available easily. The GnRH and goserelin amenorrhea improves the anemia and reduction in the uterine size and fibroid volume within 3 months of initiating the therapy has been found. So it can be used only as a pre-surgery or in perimenopausal women who wish to avoid the surgery. But pre-surgery usage also has its own shortcomings, like obliterating the site of the pseudocapsule and thereby making the dissection very difficult. LNG-IUS, that is the levonorgestrel intrauterine system, the T-shaped device composed of the cylinder with 52 milligrams of levonorgestrel releasing 20 micrograms daily for a period of up to 5 years. It induces the endometrial atrophy. It promotes the rapid residualization of the endometrial stroma. It acts on the uterine vasculature and the receptors of the myometrium and thereby tries to reduce the size of the myoma. It does not interfere with ovulation. Who are the candidates who can benefit from these are in women with heavy menstrual bleeding with a fibroid less than 3 centimeters dilated, which are not causing distortion to the uterine cavities, although some studies have shown that it can be used in fibroids up to 8 weeks size. It treats the endometrial hyperplasia and ovulatory menorrhagia and also has a contraceptive benefit. Contraindications: wherever there is a presence of acute pelvic infection, severe distortion of the uterine cavity, suspected pregnancy, abnormal or unexplained uterine bleeding, and uterine size more than 12 weeks are relative contraindications. The Elsevier study, the systemic review, shows that significant decrease in mean blood loss, significant rise in the serum hemoglobin, ferritin, and hematocrit after LNG use, greater reduction in the menstrual blood loss with LNG use as compared to combined OC pills, slight reduction in the uterine volume, beneficial effect on decreasing the endometrial thickness, and no adverse effects on the ovarian function. Whenever there is a device expulsion, it occurs more so in leiomyoma whenever there is a menorrhagia. So menorrhagia in the presence of leiomyoma is a relative contraindication for insertion of IUD, and the other side effects like irregular bleeding, spotting, and amenorrhea can be seen. The efficacy of LNG IUD was studied again in AIIMS, and they found that there is a significant reduction of the blood loss. Treatment with elagolix alone was associated with reduction in fibroids and uterine volume, with 300 milligram BT dose producing an insignificant reduction compared to the GnRH. The low dose add-back regime had marginal effects on heavy menstrual bleeding endpoints and substantially reduced the frequency of hot flushes. Add-back reduces the hot flushes associated with the drug elagolix, and role of bone mineral density is not clear and requires longer follow-up studies. Elagolix plus low-dose estrogen or progesterone add-back therapy may represent an additional long-term treatment option for women with heavy menstrual bleeding and uterine fibroids. The drug raloxifene belongs again to the selective estrogen receptor modulator group. It exhibits a bivariant effect. It has some beneficial estrogenic activity on the bone and lipids. It is anti-estrogenic activity on endometrial and breast tissue. Given in 60 milligrams dosage per day, there is insufficient evidence to conclude that the SERMs reduce the size of the fibroid. They should be used in caution since the safety of SERMs is uncertain, and further studies are required to establish the evidence of benefit of SERMs in treating women with uterine fibroids. Ormeloxifene versus OC pills in management of abnormal uterine bleeding due to myoma was another study conducted in AIIMS again under the authorship of Alka Kriplani and Asta et al. They found that whenever we are giving gonadotropin a GnRH agonist, the help in relieving the symptoms like menorrhagia, dysmenorrhea, pelvic pressure, and also may help in the correction of infertility. Whereas other drugs like NSAID helps only in dysmenorrhea. Combined OC pills are effective in dysmenorrhea, menorrhagia. Long-acting DMPA helps only in dysmenorrhea, menorrhagia. LNG IUS, dysmenorrhea, menorrhagia, whereas GnRH agonists have beneficial effects for all the 4 symptoms which are mentioned.
Excuse me, ma'am. Rajshri, ma'am.
Yes.
Ma'am, please wind up.
Okay, last 2-3 slides, ma'am. That's all. I'm towards the end. So, preoperative medical therapy for surgery for uterine fibroid. Preoperative gonadotropin GnRH agonist reduce the volume. The blood loss and the operative time can be reduced. Ulipristal acetate may offer similar advantage, and pre-treatment with the gonadotropin releasing hormone analog or ulipristal before hysterectomy and myectomy should be considered if uterine fibroids are causing distortion. Take-home message: studies with selective progesterone receptor modulator is a change in the paradigm shift of the treatment of fibroids. It has proven efficacy and favorable tolerability profile. It is not only for the preoperative treatment of moderate to severe fibroid-associated symptom, but also for long-term medical management. The patients who are unfit for surgery and pre-menopausal, it could be on the standalone treatment. SPRM is a new, effective, well-tolerated option for symptomatic fibroids in reproductive age. Mifepristone is a promising drug with effects comparable to GnRH agonist and lesser side effects. So, it is an effective long-term medical alternative. When the women take care of their health, they become their own best friend. So, thank you for the very patient listening and giving me the time to express my thoughts.
Thank you, Rajni.
Over to you, ma'am.
Durgadas sir.
Yes, thank you. At the outset, I thank the team of Happy Learning for giving me this opportunity. Dr. Rajeshri Palladi, it was an excellent presentation. To compile your talk, I can put into three things. First is the indication. The first indication, I can say, it is used in mainly 2 cases. One is infertility with the fibroid. Second is a lady, symptomatic fibroid in a lady with perimenopausal age group. She is having symptoms and she is supposed to attain menopause by another 3 to 5 years. Definitely, there is a good role of medical management. With respect to infertility, nowadays the infertility interfering, the fibroid interfering with the infertility is more, especially if it is in the submucous place and the size is around less than 3 to 5 centimeters. Definitely, there is a role of medical management for fibroids. Number one. Number two, the second thing with the drugs used, we have to think nowadays the low dose of vaginal danazol is coming back with its own merits. We have to think of using. Shortly, it's going to come now. Probably the low dose of vaginal danazol with lesser side effects. Lastly, with respect to the medical management, see, we use injection leuprolide for fibroid management. Here, the patient is having amenorrhea with thin endometrium, whereas you use ulipristal or mifepristone. Here also, the patient will have amenorrhea, but the endometrium will be thick. You should have a constant monitoring of the endometrium, because though they say there is no atypical changes, it is going to be cystic and glandular changes. It is not hypoplastic endometrium like leupride. Though if patient is having amenorrhea, they are going to have thicker endometrium. So the regular monitoring with the ultrasound scanning or if needed papal biopsy should be thought of. These are the three things I want to put into the talk. Excellent talk. Coming back to Patel sir, you are not only good academician, you are an excellent, affectionate person. We all wish to see you as the president of FOGSI.
Thank you.
Yeah. Meantime, I wish all the best to our own Kasoga president Vidya Tobbi, Asha Jain, and our beloved Bharati Rajshekhar. We want to see all of you in the national forum. Thank you for the opportunity given. Sir, I am traveling to Bangalore, so it's very difficult. I don't know how far I was clear. Thank you, sir.
You are very much clear, and it shows your commitment and our bond of relationship, which is so strong now. And you are always with me in any of my activity. You have always encouraged me in my activity, and you have joined. Even if you are traveling, it shows your commitment and love to me. Yes, thank you, Asrana sir. Thank you.
Thank you.
Thank you, sir. Thank you, Rajshri ma'am. Requesting chairpersons to have another word if they wish to say something.
Thank you, Rajshri ma'am, for an excellent presentation. It was a very good presentation on the medical management, stressing on the transition of the progesterone, transition from the progesterone agonist to the progesterone antagonist. More stress was put on the selective progesterone receptor modulators than compared to the SERMs. So it was an excellent presentation, ma'am. Thank you, Rajshri ma'am.
Thank you. Thank you, Usha.
Thank you, madam. Thank you, Rajeshri madam.
Thank you, Suguna ma'am.
Thank you, respected chairpersons and Rajshri ma'am.
Thank you,
I'm
ma'am.
really sorry I had to interfere.
I was to the end, ma'am. Thank you. No problem.
So now I think we start the panel because we are 20 minutes late for the panel. So may we start the panel now?
Oh, yes. Oh, yes.
Thank you, MC Patel, sir.
Yes, welcome.
Thank you, Dr. Rajeshri. It was nice.
Thanks, Bharti.
No, this is Rekha.
So thank you, everyone, for this excellent session. And now we proceed to the panel. The panel is on medico-legal issues in obstetric gynec practice, and it basically concerns the Consumer Protection Act. I would like to introduce our moderator for this session, and he's none other than respected MC Patel, sir, a very well-known figure, but still my pleasure to introduce him. He's a consultant obstetrician gynecologist and medico-legal counselor, VP FOGSI 2018, Organizing Secretary AICOG 2017, Chairperson Ethics and Medical Legal Committee FOGSI 2011 to 13, Honorary Secretary SOGO Organizing Chairperson MMCon 2018, Honorary Member National Inspection and Monitoring Committee, PNDT Act, Government of India in the year 2015. He's Honorary Member State Supervisory Board, PNDT Committee, Gujarat 2005 to 9, President Ahmedabad Obstetric Gynec Society 2010 to 11, Honorary Member National Managing Body, Indian Red Cross Society 19 to 22, National President, National Medicos Organization 2016 to 18. He's still very active in that. And for the last 21 years, he's been going to the Northeast to deliver free medical care to areas which are not easily approachable. Kudos to you, sir, for that. President IMA Ahmedabad 2007 to 8. Honorary Surgeon, Indian Red Cross Eye Bank, collected more than 1,000 eye pairs and was the organizing chairperson of Vivekanand NMOCon 2013. Sir is going for President Foxy this year, and I would request everyone to hear this appeal.
Shubham karotu kalyanam arogyam sukha sampadam.
Respected seniors and dear colleagues, serving Foxy for years together on this auspicious day with folded hands and down head, I seek your guidance, blessings and support to endorse my candidature for the post of Foxy President year 2026, election year 2024. Consistently working for Foxy and trying to visit even smaller societies and to assist our common Foxyian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So now we will start the panel. We have respected panelists from Karnataka and all very knowledgeable people, but I will be introducing them as the name comes along. Before we actually start, sir, I have a query that will actually introduce the topic. And the query is Consumer Protection Act. Is it worth discussing or we just take it for granted?
No, it is worth discussing because as far as medico-legal consequences are concerned, they are increasing in number constantly and steadily. And as far as our fraternity is concerned, we gynecologists rank first, and that is why it is very much required to discuss. So usually any patient or patient party, when they are aggrieved, usually they prefer to go with 3 different areas. Some are interested in compensation. Some are interested to go for criminal action to be taken against doctor, and some are interested to take any disciplinary action on part of doctor from their respective bodies. So they may prefer litigation in any fora, but CPA is a very important thing to know and discuss, because as far as compensation part is concerned, usually patient and patient party prefer to go in CPA. Of course, there are one more area also as far as this compensation is concerned. In civil court also they may go, but in civil court there are 2 things. One, whichever amount they are claiming, 50% of amount is to be deposited in that very court, and it takes lots of time to decide. So usually they do not prefer to go in civil suit, but they prefer to go in consumer fora, respective fora, district, national or state, as per the case may be, and we have to face litigation in that very fora.
Thank you, sir. So now I would like to introduce Dr. Nagaratna Kuntoji, who is the president of Bagalkot Obstetric Gynec Society. She loves gardening, social service, and is very inclined towards spirituality. And that you can see in her garden. See. Beautiful, with a meditation mat there. Over to you, Nagaratna ma'am.
Thank you, madam. Good evening, everybody. Good evening, MC Patel, sir.
Yes, good evening. Welcome, madam.
Sir, we all know that Consumer Protection Act, it came into existence in 1987, though the bill was introduced in 1986. And this act was repealed in 2019, and again a new act was formed. And our medical profession, it came under the purview of this CPA in 1995. So, would you highlight what was the difference between the original CPA Act and the revised Act in 2019?
Actually, you rightly mentioned, this Consumer Protection Act was enacted long back in 1986, and it was basically for consumer. Consumer means person who buys anything against consideration. So person who pays for that very thing and he purchases something, and if he agreed with that thing, then he was allowed to go for litigation against the person who has provided these services. Medical fraternity were not under that CPA at that time. But afterward, there was famous case of VP Santa versus Indian Medical Association. And in that very case, Indian Medical Association lost the case. And then after medical fraternity was included under this CPA Act. And then onward, medical services are also considered in CPA Act. So any of our patient is considered as a consumer, and we are considered as a service provider. So after that CPA Act and this amendment which came in 2019, but since then medical fraternity is under this CPA litigations, etc.
So, what is the difference between that act and revised act? So, what anything new is introduced in this, or any
There are
change in the?
so many new things, not one. As far as this change in this pecuniary jurisdiction is concerned and territorial jurisdiction is concerned. So territorial jurisdictions means previously when cause of action has happened, patient or patient party were allowed to file complaint in that very area. Say for example, patient has taken treatment at Belgaum. Then in jurisdiction of Belgaum, only patient can prefer litigation under CPA. But now with amendment in 2019, it is totally changed, and now patient can file complaint against anywhere, from anywhere, wherever patient lives. Say for example, if patient has taken treatment at Belgaum, but if patient is residing in Gujarat, then from Gujarat also he or she can file complaint against doctors. So this is change in territorial jurisdiction. As far as pecuniary jurisdiction is concerned, it was changed. Previously, up to 20 lakhs in district forum, more than 20 lakhs and less than 1 crore in state commission, and more than 1 crore then in national commission litigations or complaint were filed. But with this change, now it is changed that previously amount which were demanded for as a compensation were taken into consideration, but now amount which is paid by doctor, I mean paid by a patient, is taken into consideration. So if it is less than 1 crore, then any complaint can be lodged in district forum also. So it is very obvious that no patient will have to pay amount up to 1 crore, more than 1 crore. So, Tirth, you mute all other. So, naturally, nobody, I mean, no patient will pay amount of 1 crore or more than that. So, all the cases are now lodged in district forum. So, this is pecuniary jurisdiction. One more jurisdiction is there is one provision that patient and doctor may go outside court settlement before they approach consumer forum. This is also one provision in this amendment which came in 2019. One more amendment also came that if you are working at Belgaum, patient had been treated at Belgaum and patient has lodged complaint from Gujarat, then every time you have not to go to Gujarat, but you can defend your case online also from your place. This is also one more provision in this amendment which came in 2019.
So it is more friendly towards the consumer than towards us.
Naturally. As such, this Consumer Protection Act, which was originally enacted in 1986, it was pro-consumer. And in that very act, in preamble also, it was said that consumer is king. Grahak evam raja. This was the sentence. So, to protect consumer from all this service providers mischief or malpractice or deficiency in service, they are protected under this CPA. But as far as our medical fraternity part is concerned, now it has become almost fashion rather. Any patient even agreed for a very nominal reason, then also they would prefer to go for litigation. Yes.
So one personal question, sir.
Yes,
So
yes.
what do you think our medical profession should be considered just like any other service, or I mean, this should have been kept out of the purview of CPA?
So the same discussion which was taken in the Rajya Sabha, and then Union Minister late Vilas Paswan, he was discussing the same issue in Rajya Sabha, and he told that medical fraternity should be out of this purview of Consumer Protection Act. So as such, when this act enacted in 1986, in the list who are included under CPA, medical fraternity was not there. But after that case, just I mentioned VP Santa versus IMA, then after, in that very list, medical fraternity, medical service provider is included. Now in Rajya Sabha, when it was discussed, so we were happy that now medical fraternity could be out of that list. But actually, there are a list of two types: list of inclusion and list of exclusion. So inclusion means these different departments or fraternities are included, that is inclusion. And exclusion, this will not be included. Say for example, government hospital where each and every patients are treated free, then they are excluded from CPA. But after that discussion in Rajya Sabha, in that very list of exclusion, still there is no mention of medical fraternity. So till then, unless it is included in that list of exclusion, medical fraternity is still under purview of CPA.
Sir, excuse me, sir.
Yes.
Sir, my request is please take structured questions first.
Okay.
We want to finish the structured questions by 8 and then we take everything else.
Oh yes.
So, sir, thank you, sir. And
thank you, sir. Thank you, madam.
Ma'am, at the end, in the open section, you can ask more questions.
Yeah, sure, madam. Sure. And
so now we have, sir, Dr. Shobha Shaivi, who's the secretary of Bagalkot Society. And her hobbies are reading. She writes also, does gardening, does farming. does recycling and composting. These are her hobbies. And you can see vegetables and fruits, those mangoes are. So over to you, Dr. Shobha.
Sir, can you please
Yes.
tell about the technical terms in the Act and please enumerate the important terms which we should know as practitioners?
Usual terms, and we are or we are known to that term also, is notice. So under this CPA, patient or patient party, they serve notice to the person. Then we reply to that notice. So it is reply to the notice. If patient or patient party is not satisfied with our reply, then they would prefer litigation in consumer fora. So consumer fora will serve a summon, or again we can call it notice from court. So it is summoned. And when we appear in the court with reply to that summon, it is called written statement on part of doctor or who is facing litigation. So this is reply to the notice or written statement on part of doctor. One more area, once we submit our reply to that consumer fora, the copy is given to patient and patient party and advocate of patient also. And from that reply, they may come up with few more question or more query or more allegation also. So we are served with that part also. And when we submit reply to that, it is called rejoinder. Rejoinder to our written statement. So these are some terms, but you have not to worry for all these terms. For the sake of knowledge, it's fine. Otherwise, it is for legal proceeding. So nothing to worry.
Sir, can a doctor be can be arrested, sir, without
So this is not under CPA, but as far as criminal part is concerned, because patient or patient party, they are free to lodge complaint against doctor in any fora. If they are interested in compensation, then civil suit and CPA. If they are to take any criminal action, then they may complain in police station or in criminal courts. Or if they are interested to take disciplinary action, then they may go in other fora also. So as far as arrest of doctor is concerned, if there is a prima facie negligence on part of treating doctor, and if investigating officer is convinced, then only doctor can be arrested. This is the guideline given by Supreme Court in famous case of Jacob Matthews versus State of Punjab, which was decided in 2005.
Thank you, sir. Thank you, sir.
Yes.
Thank you, sir. So next we have Dr. Shweta Patil, who's the secretary of Belgaon Society. She didn't send me photos, but her hobby is gardening. So, Dr. Shweta, over to you.
Yes, ma'am. Thank you so much. Thank you for the opportunity and thank you so much, sir. It was a great pleasure when you had visited Belgium. It was very nice meeting you. And my question is already you have answered what is notice, but I think definitely it's a nightmare for all the doctors here. So, who can serve notice and how should we handle when we get a notice or a summon?
Yes. Actually, what is notice? Notice is a very common term. We usually consider that whenever it is served by advocate, then it is considered as a notice. But it is a misconception. As such, any letter, I repeat, any letter from patient, from relative of patient, from voluntary registered organization, or from advocate on behalf of patient or patient party, demanding some explanation. It is not necessary, it is always for compensation. But many times they may demand some explanation about treatment given or demanding compensation for alleged injury and or residual effect and or death in few of the cases. So whenever this type of letter is served, then it is called a notice. And when it is served by honorable court, that is district fora or state commission or national commission, or any other court, then it becomes a very legal one and you are under obligation to comply. Yes, you use a second question, who can serve notice? As such,
Yes, sir.
patient, patient's next kin, patient's legal heir, patient's relative, advocate on part of patient, any registered legal organization also can serve a notice. Even from government also you could be served notice if patient or patient party has complained in government. You may serve notice from medical council or NMC also if they have preferred complaint against you in NMC or MCA. So these are the areas from where you may be served a notice.
Thank you, sir. Thanks a lot.
Yes.
So next, we have Dr. Subhash Mudanur, who's the president of Bijapur Society. Sir, I could not connect with you on phone, though I tried. So, sir, just share your hobby and then you can proceed with your question.
Good evening, sir. Good evening, madam.
Yes, good evening. Good
Sorry,
evening.
I have not made any slides. My hobby
No,
is.
no issue. No issue. You can
I
ask.
have not made any slides. Sir is the most respected person. Most he is like a mentor for me, God, a father. And sir, I am into teaching. So for the last 33 years, I am into this job only. I do not get much time for hobbies, but I do agriculture, horticulture as a passion. We grow different fruits like bananas, pomegranates, grapes are very famous in our place. We I actually we weekends and holidays I engage myself in those activities. My favorite passion is how to conserve water. I teach all agriculture people. Each drop counts. What our Prime Minister Modi says. So literally we practice that because this is an area like Bagalkot, Bijapur. We are doing that, and people are encouraged to see that how water can be conserved and use it for agriculture. That's how I do. And my question is very simple, like two, three small questions. Sir, the one people have made earlier is in our times we never heard. They have made very popular this terminology called medical negligence. Anybody literate, illiterate person can talk about medical negligence. There is nothing like a judicial negligence. There is nothing like a negligence,
Yes.
banking negligence, or police negligence, political negligence. Why they have made it so much that anybody can, for anything, they can use this terminology. Even TV people immediately they tell that it is a case of medical negligence. They become judgmental. They cause a lot of reputation of the doctors. How the associations like Foxy, IMA, or all those things can counter this? I got second question, please. This. Yes, sir.
Yeah, the same discussion had been in past in a length that why word medical negligence is used. You have rightly pointed out that there is no word like judicial negligence, no word like police negligence. Then why medical negligence? But for any reason, it has become so common word to be used by even lay people also that there was negligence on part of medical person who was treating the patient, and it has become very common word. But you are very right. Indian Medical Association or Foxy or this type of organization take this issue at a large scale, and this word can be abolished from normal conversation. Yes.
There is one more thing, sir. What we commonly suppose there is actual negligence, what they define it is hacked. If I treat a very poor patient, say his or her income is only say 10 or 20,000 per month, and there is a compensation to be awarded, the court will award a different. And if I charge the same thing to a rich person, same bill for, and there is some negligence and it is proved, the compensation might vary from few thousand to few crores also.
Yes,
So
yes.
why there is such a thing? Whether
Yes.
we can charge depending on their income also, there should be provision so that we are to be awarded like that.
So as far as any charge to be collected from patient against our services, in law there is no limit. One can charge any amount of fees, but as per your services, you can charge accordingly. That is the way. As far as this amount of compensation is concerned, sorry, in famous case of Prasant Dhanaka versus Nizam Institute of Medical Science, in that very case, it was decided how amount of compensation should be decided. So in that very case, it was decided that age of patient, if there is death of patient, then probable expectancy of that very patient, what he or she was earning at that time, and how much amount she would have earned till that very age, her or his family responsibility or probable expense on part of his or her. So that way, all the parameters are taken into consideration. Then medical expense, and if there is residual effect, then for rehabilitation or for further medical care, how much probable expense could be. So considering all this, they went with, in that very case, amount was past 1 crore. And then after very famous case came, that is case of Kunal Saha versus Emory Hospital at Kolkata. And in that very case, compensation came to be 6 crore and some lakhs, and with interest it went up to 11 crores and some lakhs. But in those, it was interpreted that person who died, of course, he basically from India, but they settled in UK, and she was clinical psychologist in UK or US, I exactly do not know. But she was earning in dollar or pound. So that was taken into consideration at the time of deciding this case. And this is misfortune of medical fraternity, I would say, because this should not be like this. Say, for example, if we have to treat Mukesh Ambani, and if something goes wrong, let us hope it doesn't happen. But if when he goes for claim, then we will be nowhere to pay the compensation. So it is a very wrong thing. And previously, in past also, it was tried on part of IMA also, that there should be ceiling or capping of compensation. But still, it is not happened.
Thank you, sir.
Yes.
So, Bhash
Yes,
sir,
sir.
if you would take these questions also. What is displayed on the screen?
Sir, madam,
So these questions that are displayed.
I should answer.
No, you
No,
should
no.
ask.
Answer, I will answer you.
You
Any
have
question.
to ask these questions, sir.
Okay, sir, to whom notice can be served? Sir, already had said.
To whom notice can be served, against whom means any service provider can be served with a notice. In short, I can say. Whether he is a doctor of any specialty, or family physician, or dental surgeon, or nursing staff, pharmacist, this X-ray technician. So any healthcare provider could be served with a notice.
So it is a sort of notice. If it is sort of official or with some intention, that becomes a letter. It becomes notice.
Whenever we are served with this kind of letter, it is notice in eye of law, and we have to reply that notice. Many times they have asked for some explanation. We may explain, and if they are satisfied, it's fine. Case ends there only. And if they are not satisfied and still they are aggrieved, then they may prefer litigations either in CPA or in civil suit or in criminal, or they may go with simultaneous complaint also.
Sir, one more regarding PC P&D Act, sir. I am in this district committee. or a renewal of PCPNDT certificate, this registration, you have to give the application 1 month prior to the expiry.
Yes.
And if it is not renewed within 90 days, it is deemed.
Yes.
Sir, but if it between 30 days and the 90 days, what happens to the registration?
So in any of my lecture related to prevention and remedies under PCPNT Act, I always discuss this matter. Though we are under obligation to apply for renewal before 30 days, but authority has a time to respond for 90 days. So I would always advise to go for renewal before 90 days.
Before 90 days.
Yes. And once you, because this application is to be done online, and
Yes.
once you lodge this application for renewal, if there is no communication from appropriate authority, either accepting or denying, then your center is automatically registered. That is deemed renewed after 90 days.
Yes, sir. That is a nice suggestion, sir. Thank you, sir.
Thank you, sir. So now we have Dr. Soumya Patil from Gulbarga. So she plays badminton, but right now she isn't finding any time for it. So Dr. Soumya, over to you, please.
Yes, ma'am. Thank you so much, ma'am. So very good evening to you, sir. And I'm very thankful for giving me this opportunity to be part of this webinar. So I'll go ahead with my question. Which are the areas for litigation?
So it is partially covered prior also. So it depends upon the patient and patient party for what they are interested. If they are interested for compensation, then they can prefer litigation under civil court or under CPA, CPA Consumer Fora, District Forum, State Commission or National Commission as per the case. If they are interested to take any criminal action against doctor, then they may prefer a complaint in police station and in criminal courts also. If they are interested to take disciplinary action against doctor, then they can prefer appeal in medical council or in National Commission also. If doctor is working in government, then they may prefer appeal in the department also for departmental inquiry or complaint to head of the unit, head of the department, head of the institution, that way. They also may prefer appeal in Human Right Commission also, in any women's cell also, and straightway they lodge complaint in government also. And many a times if they are interested to harass us, then they may lodge complaint simultaneously for CPA, for criminal action, for Human Right Commission, for medical council, in government also. And there are bombardment to us from all those respective departments, and they served us a notice and we have to reply those notice.
Okay. So like there is no limitation.
Yes, there is no limitation.
Okay. So my next question is, who can be an expert witness?
So any person can be expert witness. Say for example, we are gynecologists and we are facing any litigation. We may invite any gynecologist as an expert witness in our favor. And same way, patient may also invite gynecologist in her favor also. And in this condition, if we have invited expert witness in our favor, then advocate on part of prosecution may have cross-examination of our witness. And if patient has produced expert witness, then advocate on part of this doctor can cross-examine that expert witness. So we should always go with expert witness. In my practice, I have a habit. I put expert witness in Consumer Fora, and it becomes very useful because in this situation, what Fora will do? Fora will give a bunch of questions which are given to that Fora from patient or advocate of patient, and all those questions will be submitted to our expert witness. an expert witness will reply all those questions. And if they are interested to examine expert witness in presence on oath, then they may request Honorable Fora, the district forum also. And if this district forum is convinced, then expert witness can be summoned to be present in court for cross-examination. Otherwise, usually expert witness have not to be appeared in consumer fora. They are served with this bunch of questions is only.
So they need to be from our own place, like they should be residing in our area.
From any place. I have appeared as an expert witness. I am residing at Ahmedabad, and for one of case from Karnataka, only from Bellary, I appeared at Delhi.
Okay. That's what I had the doubt, because if we want, can we approach you from different areas?
Expert can be invited from anywhere, India.
Okay.
But preferably, if you invite from government medical college, then it has a special weightage because they are considered as an expert and non-biased person.
Okay. Thank you so
Sir,
much.
can I, excuse me, sir?
Yes.
Can I just ask a question
Yes,
in
go ahead.
relation to this?
Yes.
Sir, in one of my colleagues' cases in the CPA, it was a case of PPH followed by death, and they asked the lawyer in the consultant side asked for the witness to call for an expert witness. However, the judge involved refused. She said, no, we don't require an expert witness, and she did not call for an expert witness.
So this is discretion of judge or court, who I would say. If they are not convinced that expert witness is required, they may refuse. But you have to try to convince honorable judge why expert witness is invited. Then usually they allow.
So because she gave a written request asking for an expert, but the judge refused to call the expert witness.
Ultimately, it is discretion of court only.
Okay.
They are not willing. They may refuse. But we should try. We should try.
Okay. Thank you, sir.
Yes.
So next we have Dr. Vasant Lakshmi ma'am. She is the president of Mandya Obstetric Gynec Society. She loves reading books, does Zumba dance, and her hobby is learning new things. So over to you, Vasant Lakshmi ma'am.
Yes, sir. Both of the question is answered.
Sir. Good evening, sir.
But you can ask any other question also. You are free to ask.
Sir, this question is also already answered. I heard it.
But
sir, thing is one more.
Yes.
When case is against us, can we call expert? One question.
Yes.
Another question.
I mentioned.
Yeah. Can a complaint can also cause the expert?
Yes. I explained that also. Both
so one more
the
question.
party are free to invite expert witness in their respective favor.
So one more question. In the emergency, what is the way we have to write the OPD slips and outpatients when emergency situation? Sometimes we may not enter anything. Sometimes we'll be treating the patients. That time, if something mishaps, then how can we substantiate that situation that?
We can prepare record of treatment given in emergency with fresh memory at any time. If police person or any investigating officer asks, then you can request them that we were busy with treating this emergency and please give us time to complete our record and we will submit as early as possible. And usually they allow. Even they do not allow, then you can write with protest that I had asked for time to prepare record of treatment given to the patient in an emergency, but they didn't allow me. I keep my right reserved to submit record at my earliest possible. So if you have submitted like this, then it becomes a good defense in your favor.
Okay, sir. Thank you, sir. Thank you, sir. Thank you very much.
Thank you, sir. Sir, Vasanta ma'am, would you take one more question? Because the secretary, Dr. Sheila Madhur from Mandya is not here. And
So-
this is a question.
So most of the time, ma'am, what the complaint is, they'll ask for the ransom money or ransom only. So that time, sometimes we won't be having any problem. Also, we mistake also. Sometimes because of this litigation, go to the court and all. So most of the time, we'll agree for that. So how can we substantiate that? That's what we steps we can take. Like how to contact, what protection we can take. No, we don't know exactly, sir, where to join, so that in that time we'll be confused what to do, whether to give money or we have to substantiate our strongly stand like that. But that time, what
Whenever,
any committee is there to join us, so that guide us in that situation,
yes,
like.
yes. Whenever you are served with a notice, or many a time telephonic conversation from part of patient or patient party, you can inform FOXI, Ethics and Medical Legal Committee, through FOXI secretary you have to go for, and your case or your information will be referred to respective chairperson, and they will respond you, and they will guide, or they will assist you rather, how to proceed in that very case. If you are unable to reach them, I am always available. You can have phone call to me, Dr. MC Patel, and I will be always ready to guide you, to assist you what to do in that very given situation.
Thank you, sir. Thank you very much, sir. So nice, sir. So kind of
I
you.
have assisted so many Foxian friends. You won't believe, in a week, I receive 3 to 4 phone calls from outside Gujarat that sir, this position has happened, and now you guide us what to do, how to proceed. And I do advise, I do guide them.
Thank you, sir. Thank you so much.
You are most welcome, and you are always free to ask me at any time.
Thank you, sir. Thank you so much.
I would suggest for that also,
Asanta
if
ma'am,
you are
would you
in a
take
little
this
doubt,
question? This
yes,
question was given to Dr. Sheila. So would you please take this question?
If we are called as an expert witness in some case, what are the points we should care about while giving opinion? This also you should know, sir.
Usually, whenever we are called as an expert witness, and court usually asks, does it seems that doctor was prima facie negligence at the time of treating this patient? So usually, one should stick to that part only, because many times what happens, expert witness who is called from government hospital or government medical college department usually, and they are asked that, doctor, do you feel that doctor was negligent in treating this patient in that very given situation? And they will not stick to that very question, and they will try to narrate like this. It would have been better he would have treated this patient in this fashion. So you are not called for that. You are called that whatever treatment given by that very doctor, all the papers are given to you for study, and from your study you have to only opine, is there any negligence on part of treating doctor? So we should be very clear in our opinion. I would like to mention one example which happened in city of Ahmedabad. It was a laparoscopic surgery, and during surgery there was sudden cardiac arrest. So in a hurry, abdomen was closed, abdominal ports were closed, and patient was resuscitated and shifted to nearby medical college. But in hurry, due to that instrument, there was some injury to bladder, and in that hospital, that patient was brought, but ultimately patient expired during the course of treatment, and post-mortem examination was done. And there was finding in post-mortem examination, there was rent in urinary bladder. And this case was referred to gynec department in medical college. So they opine that cause of death could be injury to bladder. Now, who will believe that can any bladder injury cause immediate death of any patient? So we have not to write this type of comments even. We have to simply give our expert opinion whether doctor has treated that very patient in a way in which any prudent gynecologist or doctor would have treated. This is our this should be our answer.
Sir, one point, sir.
Yes.
Whether we can contest expert's opinion, like he is not giving correct, you take another expert
We
opinion.
can challenge.
Yes,
Even we can challenge also them, because in one of the case I would like to mention, post-mortem examination was done, and forensic medicine person who head of the department from Medical College Rajkot, he was in court, and I was there to defend our doctor. So he started like this. This patient was treated very inefficiently, and there was so many negligence in treating this patient on part of doctor. So I asked, doctor, have you seen, or are you in a practice that you see living patient? You have done post-mortem examination. You have to simply opine what is the cause of death and what is the time since death. That's all. Otherwise, whether treatment was correct or not, whether negligent on part of treating doctor was not, it is not purview of a person who is doing post-mortem examination. So in this type of situation, we can challenge opinion from expert also.
Yes. Thank you, sir.
Sir.
Yes.
So next we go to Dr. Shailaja Chinmay, who's the secretary of Tumkur.
Ma'am, she isn't here, I think, ma'am.
Huh?
She
She's not
isn't
here?
here, ma'am. She is
Yeah,
not
please
here.
take the question. Please take the question.
Yes, ma'am. Sir, my best wishes to you, sir, and thank you for the opportunity, sir.
Yes, yes.
I'm from Tumkur Obigain Society, and I'm the chairperson for Medical Disorders Committee, Kasoga, sir. So I'm taking this question on behalf of Dr. Shailaja. Sir, what is a written statement?
I mentioned prior also, when you are served with a notice from any consumer fora, district forum or state commission or national commission, and when you reply that notice or that summon, it is called written statement.
Sir, this written statement, we are giving it to the patient or to the court, sir?
To the court.
To the court.
But copy of the same, court will give to the patient or patient party.
Okay.
We have to submit in court. If court has specifically asked that in 2 sets, 3 sets, then that way, and that one copy will be given to the patient.
Okay, okay. Thank you.
So this is Dr. Rachna. She loves traveling and books and painting and see her adventures. That is scuba diving. So she's already introduced herself academically. So over to you, Dr. Rachna.
Yeah, thank you, ma'am. So when is a written statement required?
Just I mentioned, if notice or summon is served through consumer fora, then we have to submit our reply, and it is called written statement.
Okay. Thank you, sir. Ma'am, you can move on to the next.
Yes. Yes, Asha madam. So till then, anybody can ask any question.
Yeah, sir. I have got one question, and that is concerning the MTP.
Yes.
So I need the clarification on renewal of MTP approval.
As such, there is no word like renewal of MTP approval. Once your center is registered for MTP, it is registered forever.
But then we get the notice from the office.
This is wrong interpretation on part of your appropriate authority. Otherwise, in MTP Act, nowhere there is provision of renewal. Once it is given, once it is registered, it is registered forever. Yes, if there is complaint for that very center that MTP are not doing as per standard norms of MTP Act, and if the person is served with a notice or registration is suspended or registration is cancelled, and if that cancellation or suspension is challenged, and when doctor wins the case, Then again they will have to apply for the registration. But it will be again restoration of registration. It is not application for new registration or renewal even. So it is very clear. So on behalf of association, you may approach appropriate authority. Sir, there is no provision of renewal, and once any center is registered, it is registered for you.
Another question is on the MTP, suspension of MTP approval. So when the party should approach, within how many days he has to approach to the authority?
Medical board, you mean?
Suspension of the MTP approval.
It is within 30 days.
Within 30 days, we have to approach.
Yes, within 30 days, we can prefer appeal against that very judgment in any court or in higher authority also.
If it is more than 30 days?
Then if we can give valid reason for delay, then court may condone the delay and the court entertains.
Now one more doubt about the art question, sir. Art,
Yes.
ART. Now the registrations have started and we have to register for the art, and those who have registered, those who have paid for the art, till I think it is 4 to 5 months, they have not got the registration for their center.
Nothing to worry. Nothing to worry. When madam, when this ART Act enacted, at that time the question was asked, centers who are already running, who are already working, and till they go for new registration, then what should be their status? And in that very act only it was mentioned that once any center applies for registration, till there is no communication from appropriate authority as far as deny or as far as approval, that center can run as far as ART services are concerned. So once you have applied, ball is in their court. If they want to play, let them play. If they do not want, do practice, nothing to worry.
Okay, sir. Thank you.
Sir, regarding, sir, one
Please,
minute.
sir, please at the end.
Okay.
Please. So,
Yes.
sir, we have Dr. Sangamesh Mathapat, who's an associate professor, BM Medical College, Bijapur. He sings and is into music. So, Dr. Sangamesh, over to you, sir.
Good evening, everyone.
Yes, good evening.
I hope I'm audible, and I'm very much thankful to you, sir, for providing me an opportunity. I'm going to have one very technical question.
Yes.
It's a very new terminology we have found here. Is what is rejoinder and what is sir rejoinder?
The rejoinder I answered partially prior. So when you are served with a notice or summon from district Kora or any other court, and when you submit your reply in a written statement way, then that copy will be given to the prosecution party, that is patient party and advocate of patient. And from that very reply, they may come up with some new contention, and you are free to reply those also. And when you give those submission to your reply which is already submitted, it is called rejoinder. So it is something addition to your reply which you have already given. And same way this sir rejoinder. So after submitting rejoinder, they may come up with few more questions. Then you can again give one more rejoinder, that is sir rejoinder.
Okay,
But that is a discussion of court also. Many times court will not entertain patient party also to go like this. Otherwise, this will not end. So whatever they have raised in their first notice or in second part, that's all. Then court will say, now no more question you can put against any doctor.
Sir, I just quickly wanted to have one practical question here. We do get many POXO Act cases at the institution, and they at the outpatient department only they come to know that we are going to inform the police and we have to go for legal proceedings. So immediately the patient said that we don't want to get admitted, but we have an instruction that we have to inform the police.
Yes.
At that moment,
So-
we will be having only outpatient slips, sir. So is it mandatory for us to have a
Yes,
Xerox
yes,
copy of
yes,
the
yes,
outpatient
yes.
department with us?
So
Outpatient
it is very clear under section 19 of POCSO. Being a responsible citizen of India, you are under obligation to inform police once you come to know that she is a victim of sexual offense. So if she is minor, and if you come to know that she is pregnant, or even if she is not pregnant but she had been assaulted sexually, then even that very patient takes treatment further with you or not, doesn't matter. But once you came to know, you are under obligation to inform police.
So is it mandatory to keep a copy of the outpatient slip, because the patient may say that it's our outpatient slip?
Naturally, because whenever you may be called in court of law also for opinion. So to justify your statement, to justify your opinion, you will need all this OPD data. So you will have to preserve.
Thank you, sir.
Even patient abscond from your hospital without taking further treatment, then also you have to inform.
Thank you, sir. Thank you.
Thank you, sir.
Yes.
So now we have Dr. Shanta Durge ma'am. For the last 26 years, she's been working on Save the Girl Child. So she's been with the governor. She's done a lot of social work. That is her hobby and her passion. So over to you, Shanta ma'am.
Thank you, Dr. Asha, for introducing such a nice thing. And thank you, Dr. MC Patel, sir. Now I will come to the question, and that is, how does the court decide compensation, which is very important one. Compensation.
I covered that question also prior. So I mentioned at that time the famous case of Prasant Dhanaka versus Nizam Institute of Medical Science. It was decided. So there are certain factors they take into consideration: age of the patient, income of the patient, and if in event of death, how much she or she would have been lived, and for those many years, how much amount she would have earned. At the same time, her or his social responsibility, I mean, familial responsibility, and considering all those points, they decide to go for amount of compensation. Then medical expense she has incurred, or in case of any residual effect, if further treatment is required, or for rehabilitation purpose, then all those factors taken into consideration. And as far as damage is concerned, if it is permanent damage, whether it is partial or full, then also compensation would be in a different level.
Sir, another question is, actually there is one more question for the compensation. Can I ask?
Oh, yes.
Yeah. Sir, always whenever there is a grave injury or whatever it is, the compensation will be too much. And paying such a huge amount for the practitioner is very difficult. So when the practitioner, private practitioner or whoever, we are not the corporate persons, we are the private practitioners, and we take the just meager amount fees from the patients. And how can we pay such a huge amount of compensation? Please opine.
So there is no limit as far as this compensation part is concerned. It was also previously discussed. So as far as fees to be collected, there is no limit. There is no law that one can collect this much fees only. But whatever fee you collect, your services should be accordingly. The court or law expect from you that way. Which kind of patient you are treating, which kind of patient you have managed, and in which given situation, accordingly you can charge. So nobody can challenge that way. But as far as compensation related to amount paid, now with this amendment in 2019 under CPA, now whichever amount they have paid, they may go in this litigation, because previously amount demanded was the decisive factor where patient can go for litigation. If she has demanded for 20 lakhs, then in district for more than 20 lakhs, less than 1 crore, then in state commission, more than 1 crore in national commission. But now it is gone. With amendment, amount paid by the patient is considered, and if it is less than 1 crore, that compensation can be in district fora. And naturally, nobody would be giving this much amount, 1 crore or fee. No hospital will have that much bill. So all the cases now are settled in district fora.
Thank you. One more question. Is there a limit or guidance?
No, as such, there is no limit, but in past IMA had also tried, but still court has not come up, or government has not come up with capping the limit of this compensation. But still IMA is behind this. So let us hope in future it may come.
Thank you, sir. Thank you.
Excuse me, sir. Related to this, can I ask one question?
Oh, yes.
So when they say it depends on how much the person was earning, how long the person would have lived, and based on that the compensation, why it is only for the medical profession? So somebody dies in some accident or something like that, then the compensation is not decided on that.
So these type of questions were taken on part of IMA, just I mentioned in past also, but still government and court has not agreed to accept all this argument, and still this fight is on.
Patel sir, please, 8:30 this will
mentioned
stop.
because
So we need to first finish the question, sir.
What happens whenever this type of questions come, you stop, because I do not know whether further questions are remain or so. That is why I am entertaining.
No, sir. Actually, your program will, in 10 minutes, it will stop. Auto cut. These two
Yes.
doctors are not there. So I request anybody to please take this. Dr.
Okay,
Neeta Harwal from Gulbarga, the past president. Anybody can take this question.
I will take for Dr. Neeta Harwal. Yeah, the question is CPA Act 2019. It removes healthcare from services. What is your interpretation?
So this is also taken by me previously, because in Rajya Sabha it was mentioned by Ram Vilas Paswan at that time. But there are two lists I mentioned prior also, list of inclusion and list of exclusion. So in list of inclusion, all the forums which can be considered under CPA, in that very list medical fraternity is there. And in that list of exclusion, still medical fraternity is not included. So unless medical fraternity is included in list of exclusion, till then medical fraternity is under purview of CPA.
What should be the indemnity cover amounts?
It depends upon your practice. If you are dealing with high risk pregnancy cases, say for example, then your compensation in this era of CPA and amount of compensation we see, it should be at least 1 to 2 crore. But if you go with indemnity with Foxy, then for 2 crores also, premium is not that much. One can afford. That premium is not that much.
Thank you, sir.
Yes.
So this is Dr. Manpreet, sir, Professor and HOD, STMMC Bijapur, music, fiction, and pets. This is her hobby. And she got into an emergency, so requesting somebody to take this question. Anybody who's present can please take this question.
Shall I take?
Yes, yes.
So I'm taking Dr. Manpreet Kaur's question, and that is, should a doctor take personal cover separate from hospital cover?
Naturally, yes. Because many times if you are not, you are working in that very hospital, and you are covered for that hospital only. And if you have served or operated any other patient to any other hospital and something went wrong, then that insurance company may not entertain you. So at the time of taking insurance, you should clarify all this, that you are mobile surgeon, you are operating at this very hospital, and you should be covered that way. If you are covered that way, then it's fine. Otherwise, it will be very difficult. And other than personal indemnity, hospital should also be insured, because many a time patient and patient party make hospital also as party. And if you are covered with any insurance company and say, for example, compensation 50 lakhs is to be paid, then insurance company will interpret that you are our member. So we will entertain you. Your hospital is not our party or our member. So they will give you 25 lakhs of rupees and rest of the 25 lakhs rupees will be from your pocket. So not to end up into this type of problem, hospital should also be covered.
Second question is, what if you own the hospital? Should there be a separate cover?
Yes, same. I answered.
Is there any recourse in CPA for non-payment of hospital dues?
Yes, not in CPA, but you can go in civil suit to recover the fee if patient has not paid the fees.
I think, Dr. Asha, this is the question for open session, no? Open
Yes,
session.
yes. Now it is an open session. We have finished
But-
with the
But
regular.
how much
Anyone
time
wants to
exact-
ask anything, most welcome.
Yes, I want to ask
Maybe
Dr.
Asha,
Suguna.
Only
Yes,
1
ma'am.
minute. Asha, exactly how much time do we have?
Sir, actually you have 4 minutes.
Okay.
Sir, now the government has made Aadhaar is not the age proof, no, sir?
Hmm.
So if a patient comes, minor age group comes with less, in Aadhaar, if the age is less, then what proof we have to ask?
You can ask any government approved ID proof, Aadhaar card, fine, if it is not considered.
Now Aadhaar card is not has age.
Birth certificate, school living certificate, election card,
If she doesn't
driving
have them,
license.
we have to wait.
Yes.
Okay. One more thing, we have a MTP registration up till 20 weeks, sir. Now it is up till 24 weeks, sir. They have not given the certificate. Can we take cases about 20 weeks?
I clarified earlier also, once your center is registered for termination up to 20 weeks in past, it is automatically registered to terminate pregnancy beyond 20 weeks, not 24 years, beyond
Sir,
20
may I
weeks.
say something? Sir, this depends on the local people. Our people did not agree to that, and we had
Agreed,
to
but-
again apply.
but-
They gave
but-
it in 1 week, but we had
Nahin.
to apply again.
You are right.
Agreed,
Asha.
but for that you can approach government also, because in MTP Act there is no provision of renewal. Once center is registered forever.
Sir, I want to ask something, sir.
Yes.
Can a patient file FIR against the doctor? And once the FIR is filed, can the police arrest the doctor directly without any
So,
other?
FIR can be filed against anybody by anybody. And police has tremendous power to arrest any person under CRPC. Under CRPC, police can arrest any person at any time without giving reason. But when this person is taken by police to honorable court, then police will have to justify why he arrested the person. So this is provision in CRPC. As far as our medical fraternity part is concerned, how or in which condition doctor can be arrested, guidelines were given by Supreme Court in 2005 during case of Jacob Matthews versus State of Punjab. And in that very guideline, Supreme Court has very specifically mentioned that if doctor has prima facie negligence in that very treatment part, then only police should approach accordingly. So in this situation, any sensible police person will collect all the evidences. He will take all the documents of treatment given. He will take your statement of your staff, statement of patient or patient party, and all those paper will be sent to respective department of medical college nearby. And if there is opinion from medical college that it seems to be prima facie negligence on part of doctor, then only police officer proceed further. So, but many times what happens when there is a complaint in police station, they will file FIR and they will go with section either 304 if there is a death of patient, and if there is no death, then simple injury, grievous injury. that way police will interpret and they will issue a notice or they will arrest. But if it is a offense which has punishment of 2 years, then these all are offenses are bailable. So at police station level only, bail can be given and you are free, and then we will have to face litigation in future. But if there is a provision of punishment more than 2 years, say for example, if they have applied section 304, then there is a provision of 10 years of imprisonment. So in this situation, it is not bailable. And once it is not bailable, then police will take you to the honorable court and only court can grant your bail. So in this situation, if you come to know that section 304 is applied, then you should abscond from your place and you will try to go for anticipatory bail, and then only you appear before police station. Otherwise, what happens if police is smart enough to arrest you, then they may arrest you on Friday evening. Saturday, Sunday court is closed. You will be behind the bar till Monday morning till court opens. So, of course, these situations are very rare, but we should be careful if at all this type of situation arises.
So can a patient file criminal case against doctor, sir?
Yes,
Sorry
yes,
to
yes,
interrupt you,
yes,
sir,
yes.
but we need to conclude it by the time.
Oh, yes, yes. But so if any question, you can give that question to me directly in my mobile number in WhatsApp. I will reply. I will answer.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you all.
Thank you, sir.
Thank you, sir.
Thank you. And humble appeal at the end to nominate my candidature for post of President Fox in month of May and election in month of August from 1st to 10. And you all have to vote for me. And same way vote for Vidya Madam for Vice President. And same way for Asha Jain Madam for Chairperson, Foods, Drugs and Medical Surgical Equipment Committee. And for Dr. Bharti Madam for Perinatological Committee. So you all President and Secretary of respective society will nominate us first in month of May and then in month of August you will put us respectively. Thank you very much.
Thank you, sir.
Thank you, Corona Remedies. Thank you, all our respected guests, chairpersons, speaker, and all the seniors who are present. I also thank all the panelists and all the viewers who have given so much of their precious time. I hope they really learned something. Thank you. Thank you again. We meet again next week on another topic. Namaskar. Good night. Shubh Ratri.
Thank you. Thank you.
Thank you.
Thank you,
Thank
Dr.
you, everyone.
Good
Okay,
night.
ma'am. I am ending this session.
Okay, you can.
Thank you, everybody. Good